we're going to have Dr. Teresa Matina give a talk this morning. And just before I forget, at the conclusion of her talk, since her talk is going to be by Skype, for anyone that has questions, you need to come up here to the computer to ask her question so she can hear you. Because she won't hear it if it's using the other external microphones, okay? So again, if you have any questions for Dr. Matina at the conclusion of her talk, you need to come up here to the podium to ask those questions. So I think all of you know Dr. Matina's long storied history with Jacobsen syndrome. I think from the other night you'll recall that she was actually the first of only 2 other physicians in the world studying Jacobsen syndrome when I first got involved back in the mid-90s. Dr. Matina is a board-certified pediatric geneticist and professor of medicine in Catania, Italy, and I've actually been very fortunate to have the honor of visiting her in Catania. Besides San Diego, Dr. Matina follows the largest number of children with Jacobsen syndrome in the world. Her interest is on characterizing all the physical features of dysmorphic syndromes and to identify the underlying genetic causes. She has also initiated work on trisomies and is really the only person in the world who's working on understanding children with trisomy of 11q. I should also say, just to reiterate what I mentioned the other day, her student at the time, Ketty Parada, is the only person in the world to have earned a PhD on the subject of Jacobsen syndrome, and that's an incredible tribute to Dr. Matina's mentoring. So it is a great honor and pleasure to introduce a long-standing part of the 11q family, Dr. Teresa Matina from Italy.
Yes. Why you are having problems with legs?
Let's just say this, I'm the only one with a problem at this conference, obviously, so not quite.
Okay. Thank you for inviting me. I'm very happy to be there, even if I'm here. It has been difficult, but we have arranged. Can you hear well?
Yes, it's great.
Okay. So this is Katie Perrotta you were mentioning before. She has done not only PhD, but also she specialized studying 11q. And Graziana Cassisi also did a specialization studying children with 11q deletion, and Elena Bratigo has helped us. This was in the past few years. Now, Katie Perrotta is still helping me, but I also have Roberta. See, here is, no? Non la vedo? No. Okay. And we also have a neurologist that has looked at all the MRIs you have given me, and a radiologist and a computer expert. And we also have Marco Fichera, a scientist who will be working with 11qs together with us. And we must remember also Orsetta Tuffati and Elena Rossi, who have done all the cytogenetics and array CGH up until now. When we review literature, we see cases studied by different doctors with different techniques for diagnosis, and especially who look at phenotype in a different way. And it is difficult to put cases together and to compare them. So we started this clinical research that is not a trial using treatment, but is observing patients in 2 different ways. Is cross-sectional and longitudinal. cross-sectional. During a conference, we observed a number of patients who obviously have a different age, and we try to figure out what the natural history is. It's a quick, not very accurate, because we want these children to become better old patients than the ones we see now. We want to take advantage from experience and make their life better. The longitudinal studies are retrospective, it means we look backwards what has happened, and prospective, follow-up of patients. This is very accurate but requires time. The best observational studies are a combination of cross-sectional and longitudinal ones, both retrospective and prospective. And this is the way I'm doing it. This is the patients I have seen so far, 153. Most of them have Jacobsen syndrome. There are some with interstitial deletion that help us defining the phenotype. But we also studied the duplications, and we also found that some patients that had been told to have Jacobsen didn't have the condition. So this research is not just observational research, but we can support the diagnosis, updating the technical for diagnosis, and we can support clinical management, and we can get suggestions for future research. So we wanted to have not just 11q deletion, Jacobsen, but also interstitial trisomies, balanced and complex unbalanced conditions. Deletions, when there is a loss, balance, translocation. In these cases, you can have a breakage of a gene, and it may be very interesting to find a breakage that, although it's balanced, destroyed one gene, or duplications. And you can see what happens when the amount of the same gene is increased. And if we get enough information, we can return information to the families, and we can return information to general populations. So we have a review of the literature concerning chromosome deletions. And this is a summary you have seen many times. The incidence is 1/100,000. Literature reports are more than 200. The main features are facial dysmorphism, growth problems, psychomotor delay, heart problems, thrombocytopenia, immunological problems. But why do we care for facial aspect? Because facial features help to recognize affected children, and they indicate an abnormal growth pattern in the facial bones and the soft tissues. And we can document a variable expression of the disease. Then we document and report an abnormal growth pattern and variability in the expression, and try to understand the reason for both. And why studying phenotype is so important? Because we want to know what to expect in a child with Jacobsen. And we also want to know if we can treat or prevent some of the expected problems. And when there is a case of unexpected problems, we want to try and understand why. Some children that may need additional attention, they may also give further clues in understanding Jacobsen syndrome. So we want to collect phenotype and genotype information. Phenotype is growth, psychomotor development, clinical features, organ malformation, And we got this information with interviews and questionnaires, clinical assessment, analyze all clinical records, photos, 2D, 3D photos, lab tests, and what I want to do much more than I did before is analyze X-rays, MRIs, EEGs, and follow-up. All the information are collected in a database and results. Family history is unremarkable unless there is a translocation in one of the pregnancy is usually complete at term, full term, but in 1/3 it stops earlier. Pregnancy is abnormal in about 36.5% of cases. There is delay in growth, there is placental abnormalities and other problems. Prenatal investigations have very frequently fail to demonstrate the abnormality, even in amniocentesis when the chromosome analysis is done. But nowadays, CGHLA is done currently, and it is less likely that we miss a prenatal diagnosis. At birth, 87% children have problems: jaundice, bleeding, cyanosis, vomiting, feeding problems, and the most serious are low platelets and heart defects. Growth. There is a short stature in the majority of patients, but the head circumference is normal or large, which is an unusual pattern for chromosome disorders. We have performed growth curves. This is our last previous work. We are now introducing more data that we have received, and I'm sure we will have ready growth curves for Jacobsen very soon. Anyway, the physical growth is, there is short stature and normal head circumference or high head circumference is confirmed. Having this data, we can see if any individual child falls within the normal curve for Jacobsen or is outside the curve. If it's outside the curve, there must be an additional problem. Why stature is short, why the head is large, why only some children have trigonocephaly? And is it good to operate? What are the risks? What is the outcome after operation? We can check height using Jacob-specific curves. We can do chromosome analysis when the curves are not within the Jacobsen normal values. And concerning with head, MRI, basal MRI would be important, and also follow-up. And if you have previous data, retrospective. Neurological evaluation of children who have had craniotomy. And also medical findings to see if there are complications when the operation has been performed. And the outcome after operation. Please, I ask for films or images to be sent via email or a regular mail, and we analyze all them all together, and we will get a much better information. Surgeries have been performed in about 90% of children, but I know only complication in 14 children over 63. I miss 1/3 of the information. I don't know if there were complications in the others. It seems that the only complication, serious always present is the need for blood and platelets. But in one case, there were one case with anesthesia problem, one cardiac arrest, one respiratory arrest, but they all went okay afterwards. And one case had pneumonia afterwards. The outcome is usually positive, but there is a relapse, especially when there is operation in eyes, ptosis and strabismus are relapsed very frequently, and ear tubes must be replaced a few times sometimes. It would be very easy and quick and very, very important to have details from operation surgery files, because this would be very important for children who must undergo surgeries to know what are the usual results. We analyze face. Some of you know already how much work we have done with analyzing faces. They are eyes, and Peter Hammond has done scans of face, and we see much variability in facial aspects. Not so closely related to the size of the lesion. So there are similar ones. This is one case that falls within the group, but there are cases that don't look like the others. And we also analyze hands and feet and other findings. Platelets abnormalities is still the most frequent heart defect. I bet that the immunological problems are almost as common as platelet disorder. What is important to know is the usually abnormal findings, abnormal platelets, vagonocephaly, but also the unusual abnormal finding. If we find normal platelets in a patient, it would be interesting. Unusual pathological findings is malformed hands, bone abnormalities we are seeing in some patients. Both groups deserve special attention. This is an unusual hands that we have seen. And we have seen skin problems, but some of these are related to immunological disorder. We do not perform trials, but we can analyze what treatment has been done and if there have been good results. Let's say for constipation, it would be nice to know how many children have constipation, how many have had treatment, and how many have had good results, and what was the best treatment. So not to try, but to see what has happened. And follow-up. We can see spontaneous facial changes, how physical growth goes on, variation in platelets amount. We know that they increase with the time, but not function. It is still bad in older patients. Outcome after surgery. Changes in heart, aortic coarctation, vascular changes. This is something I have seen in the recent cases, and I have gone backwards and see that some patients have vascular stenosis, not high aortic stenosis. Scoliosis, something I see in older patients, and also obesity becomes a problem later on. Skin problems, clinical management can be followed, and cancer risk. I don't know of any child with cancer, but on Facebook there is information. Facebook information, I cannot use it, but but it would be very useful to have information about children with any cancer. And also death. We know that there have been deaths, and it would be very important to understand what has happened to prevent it in other children. Paul, please, if you have any information, let us know. With genotype, we want to know the breaks. We use the traditional karyotype, fish and array CGH so far. Now it's time to go into next generation and expression studies. Traditional karyotype has a low resolution. Fish gives a better resolution. CGH array gives an even better resolution, and can be the resolution can be tailored according to the how much interest the breakpoint has. These are some of our breakpoints. These are 19, 120, 120, 121. They look very close together, but in this case, the breakpoint was within the fragile site. And when there is a fragile site, the chromosome breaks and loses pieces. There are pieces of chromosome that go away. So the fragile site is not exactly at the same place where the break is afterwards. The break is higher up. So we may have children with the fragile site with a different breakpoint. And you may remember, Paul, this picture, because we had thought that maybe fragile sites were responsible for some breakages. We are evaluating this hypothesis again, because when we analyze breakpoints, some of them look the same, but when we do details, some are actually really the same, others are not. So these lie in the same place, could be related to the same cause, some lie in different places and could be related to other causes. And you see, these breakpoints are different, but there are some that lie within exactly the same region. And this may be interesting. They may fall in another kind of fragile site. Then I show you this region between 114 and 119. This is a region where we have never seen a deletion. This region has never seen deleted, so there may be very important genes in this region. The consideration is that these are two patients with the same breakpoint, exactly the same break, but one has flat forehead, the other one has hygonocephaly. Why? Same breakpoint, one normal feet, the other a huge big toe. Why? And this is my patient with the smallest deletion. And using information from interstitial, we can reduce, the area for Jacobsen facial aspects. Some patients are non-typical, and we cannot use those for facial information. But I think we can split this region into two and find the gene within this region. This is literature, and these are other malformations. We see that children that have wide deletion, but also small deletion up to this, show this particular phenotype, and this up to this show this particular phenotype. So the gene must be within this small region. you that most of the skin problems were from immunological problems. What is next generation sequencing? Is the analysis of all the genes. Maybe we can start with all the genes in the normal chromosome 11 that have not anymore the twin gene because of the deletion. So these genes are unique, and this can be very interesting to check. And but we can also do next generation sequencing of all the genome of a patient. Expression studies from DNA, before you have a phenotype, the cell is RNA and then protein. Instead of analyzing only DNA, we can analyze protein or RNA. There are children that don't have only 11q deletion, but have also some additional imbalance, or trisomy for something else. Usually are more severe, and we can find unexpected findings. We keep them separate. So to draw conclusions, it's important to use the same criteria for clinical assessment and for technical analysis. It would be very important to have 3D analysis, follow-up, and keep updated technologies. To be done. Growth curves are almost ready. Immunological problems are being studied. I want to be concerned with scoliosis and other skeletal abnormalities, MRI findings, skin still, but also outcome surgeries and causes of death. This is most important. New technology. We want to understand the causes for rearrangements, map individual clinical findings, understand the reason for variability, and improve clinical management. At the diagnosis, in the neonatal period, the follow-up, we can help with clinical management. I think Paul has already showed something like that. Paul, in the neonatal period, heart malformation, difficulty in feedings, bleedings, early craniotomy, and follow-up, clinical evaluation, cardiac evaluation, ophthalmological evaluation, auditory test, immunity, hormone. Each patient should have a complete checkup. And then a follow-up that must be tailored on the patient. Always consider platelet as abnormal and keep in touch so that we can update information and technologies. And I have finished my speech.
If anyone has questions for her, you'll need to walk out there.
Sorry, I can't hear you.
If anyone has questions for Dr. Matina, please come forward to the laptop and ask your questions here.
While we're waiting, Teresa, I just wanted to thank you. That was fantastic, and I just wanted to take advantage of everyone being here in the room to just emphasize how important it is. If you can try to fill out the questionnaires that Dr. Matina is asking all of you to complete, and also if you can provide her with any imaging studies of the brain that your children have had, that is immensely important, because we would like to see if there might be any structural abnormalities that would correlate with any of the cognitive and behavioral problems that we're finding, that we could then help to understand the genetic basis of. So again, I can't emphasize enough the importance of that. So Teresa's email is just matina@hotmail.com. Teresa's emailing probably the best way.
It's .it.
Oh, whoops, sorry, see it was cut off there. So don't listen to anything I just said. Anyway, we can get you the correct email. Don't listen to me about that. But is email the best way for people to be in touch with you, Teresa?
Anything. Email, traditional mail, telephone, anything.
How about a personal visit?
Yes, I'm having personal business.
Okay, so Dr. Matina will pay for anybody who would like to take a trip to Catania. Thank you, Teresa. You are very popular now. Are there any questions from the live stream? No. Okay, does anybody have any questions here in the room? Okay, I think, Teresa, you have covered it all. There is one. Dr. Stein is going to come up and ask you a question. You need to come up here. We have a...
Maybe you can get...
Okay, I'll convey it to you. Go ahead. This is from one of the parents, Teresa. Hang on.
Dr. Matina saw people here a couple of years ago.
Yes.
Do you want that information as to refill out forms and all that?
I think Dr. Matina would love to continue to get any updated information about your children, because one of the most important parts of her research is to follow the natural history. So since the last visit, the fact that your son ran a 3-hour and 20-minute marathon, I think would be of great interest, among other things. So in all seriousness, any updated information is tremendously helpful and important. Where are you, Marty? Okay.
Hi, my name is Dr. Marty Stein. Thank you for that very comprehensive review. You mentioned follow-up several times, and I'm curious that in your community or in Italy, what level of follow-up and cooperation do you receive from general practice physicians and pediatricians in the community that follow the children in your cohort?
In my place, we have a free pediatrician for everybody until 14. This is paid by the state. And there are free analysis and tests up until 6 years. And then there is a ticket to pay, a small amount to be paid by patients. My patients in Italy have every year follow-up. Any patient of mine with any chromosomal disorder. Is this the answer you wanted to hear? Have I answered?
Oh, in large part it is, but I was curious about the medical care they receive in their own communities with regard to the complications of Jacobsen syndrome.
I don't understand the question, I'm sorry.
Well, what kind of medical care do they receive throughout the year when they only come to you once a year for
They are followed by the private pediatrician, and then can access the hospital anytime they need, and surgeries anytime they need. This is free. It's from state. Is that an answer?
Yes, thank you. Italy has a different form of healthcare system than we
I don't know
have.
how long it's going to last.
True for ours, too.
Our current one, right.
None of us know how any of our healthcare systems are going to last. Any other questions? It looks like there's a live stream question, so hang on, Teresa, while Tim conveys this to me.
You can say that for her. I have an 8-month-old daughter with...
I can't hear.
No, hang on. He's going to read it to me, and then I'm going to relay it to you. So if I have enough of a short-term memory to do that, so.
I have an 8-month-old daughter with JS. It is our first child. We karyotyped my exams and my wife, and it showed no change. As we do not know the cause of the deletion of letter Q, which will we have new case in our family?
Okay, so I think the question is about recurrence, and actually, so the question comes from a parent who has an 8-month-old that was diagnosed with Jacobsen syndrome. And if I'm understanding it correctly, the parents have had karyotype analysis done on their peripheral blood lymphocytes, and that was normal. And so the question is, what are the chances of a recurrence, if I'm understanding it correctly? And we actually have a session dedicated tomorrow with Dr. John Johnson from Tufts University, who's going to speak exclusively on the subject of recurrence. I can give you a quick answer, Teresa. You can chime in as well. You want to start? Teresa, go ahead.
Yes. Unless there is a translocation, the chances are very, very low. We cannot exclude a mosaicism in one of the parents. And even in the case of a fragile site, recurrence is very unusual.
So from my personal experience, I know of 3 cases from around the world in which there was a recurrence when both parents tested normal by analyzing their peripheral blood lymphocytes. And you'll hear more about that tomorrow, but as far as how that can happen, it's basically what Teresa just referred to as germline mosaicism. We'll talk about that more tomorrow. So about a 1% chance of recurrence, roughly, when both parents appear to have normal chromosomes.
If we are in touch with these parents who had the recurrence, we can check if there is a fragile site.
Yeah, so one of the families is from here in San Diego. That's the Ibarra family. There was a paper published on this from a group out of Egypt, if I'm remembering correctly, so we should be able to find that. And then the third family is the Bolton family from England, and we could certainly study them. Those are the 3 that I know of. Do you know of any others?
No. I know of cases of mosaicism in parents, but not even in this case, not recurrence.
Any other questions? Okay, so Teresa, for now we will say ciao and a big grazie. And
I would like to emphasize that I would like to hear again from patients who I have seen already, to have news and to have information about anybody who has more serious problems, about deaths and about cancers, everything, and surgeries, problems with surgeries, and even no problem with surgery is a good news that I can use.
we have actually one more question, and before I pass it over to her, I should also say, if you're interested, Teresa, tomorrow we also have a session dedicated to mortality in Jacobsen syndrome.
Who is speaking?
Yours truly, but with the participation of all the families here. So I'm going to just start out talking about the deaths that I'm aware of, and then we'll really open it up to discussion. And if you'd like to be part of that, that would be great.
Yes, I would like to. What time?
Can someone look on the schedule real quick? It's tomorrow morning our time, so it shouldn't be past your bedtime. It might be about dinner time for you.
Yes, I will try to keep.
So it will be at 10:15 our time, which should be 7:15 your time tomorrow evening.
Okay.
Okay?
7:15.
And I have...
And this will be through the link.
Okay, sure. Yeah, that would be perfect. And then Joy Robertson has a question for you.
Yes.
Hi, Dr. Matina. Thank you for being with us. Can you hear me?
Yes.
Okay, so I have one of those rare anomalies of a child with Jacobsen that has no abnormal platelet function at this time. She's 3 years old. And I know that Dr. Paul's theory is that, excuse me if I misquote you, but that all of our children with Jacobsen's carry Paris-Trousseau. I'm curious, she's undergone surgery, has had no difficulty whatsoever. It was for a typical toddler removal of the lymph nodes, nothing related to JS. What are your thoughts about her future and what we need to be watching for, if anything?
I think we should check her function now. The function of platelets has been checked, I suppose, not just the number.
It's my understanding that they have. that they've been very thorough.
This is very important, that the control of the function of platelet is done by somebody who is very, very competent in Paris-Trousseau syndrome. Because it is better to assume that your child has Paris-Trousseau and be safe, rather than assume that it's normal without a very thorough analysis.
They always institute the bleeding protocol just under the possibility whenever she's been in any sort of surgery care or inpatient.
Yes, and that's fine. But please, if you email me your address, we can see if there is anything to be done in addition.
Okay, we're Facebook friends, so I'll find you that way.
Thank you.
Thank you.
Hi, Lindsay, I see you.
Isn't this wonderful? By the way, again, thanks to Tim and Cindy, who have made this so spectacularly seamless to make this happen. Is there another question by somebody? Was there? Who are you pointing at? Each other? Curtis, did you have? Oh, and Curtis, thank you. Sorry, not to be ignored. All right, my last words to you for now, Teresa, is I'm terribly sorry about the World Cup results. So you don't care, and I don't believe you. Thank you again. Ciao. We'll talk to you soon. Bye-bye.